my task is now to continue with some general remarks about wound cleansing and wound care. And this, as I said, would be more general and not directly associated to the diabetic foot ulcer and to the procedures applied in the study, but rather giving you some background. And going back again to history, wound care probably is as old as mankind is, since we believe with the development of humans, care developed also, because you started to care for your injured companion or partner. What was used in history is very interesting. There's a very funny and nice paper published in 2009 about the history of wound care. And what you can see is that every culture, every people, every population used what they had. So if you live at the seaside, you use seawater. If you live in the Nile area, you use mud from the river. And if you are a Imker, you say in English, I don't know, you use bee honey or propolis or whatever these bees produce. And if you happen to live in Spain, you of course use olive oil. And if you live in the mountains here, you use murmeltier fat or whatever nature provides to you. And what you think is good is positively associated. So this is the history that continues up to the current time. One cut probably is in 1962, and this is the beginning of moist wound care. So this probably changed the field a little bit, and I will show you this data shortly. Another brief comment is wound care is always associated somehow with war. There are always times of war, and during wartime, of course, injuries, the incidence of injury increases, of course, dramatically, and becomes very important to the population, because you want to heal your soldiers as soon as possible, to bring them back into the field, and there's always some war around. And this is a paper from Nature in 1942, and of course there was a big war. And the guy here, a surgeon, wrote about wound care, of course, with the purpose of the background of the Second World War. And the sentence I want to draw your attention to is, and this is 1942, yeah, this is the past century. Literally thousands of materials have been suggested for promoting wound healing. So they had the same problem that we have today. There's a lot of stuff around, and you don't know what to use primarily or secondary and so on. And even if a list of such materials, namely diet, hydrogen ions, zinc, maggots. So the list even doesn't look very different from what we use today, and this is 1942. But as I said, in 1962 the field changed a little bit, because an orthopedic, I guess, named Winter developed what is called moist wound care. And also the paper is very interesting to look the original paper up. It was also published in Nature, and it not only tells you what he did, it also tells you about how science worked at this time. Because what he did is he injured laboratory pigs and treated them differently. Either did nothing or put a kind of occlusive dressing on the wounds, and found, of course, that the occlusively dressed wounds healed faster than the others. And this is the main data from this paper. And you see he had 6 wounds in one group and 6 wounds in the other group. And this is the difference he found. There was not even a standard deviation given here. So this was the standard of science in the 1960s and was published in Nature with 12 wounds. No? We couldn't do this today, I guess. We couldn't. There is not even a minor journal where you probably could publish such a study. But this was the standard of the time. And it needed 1 year. So in 1 year later, the same experiment was done in humans. So this was the first study in man with what we now call moist wound care. And then there are two interesting facts here. First is that they did it in man. They did the very same as Winter did in the pigs. They injured volunteers and put these occlusive dressings on the wound. And the other thing is interesting and shows you how clinical research developed from the 1960s up to now. The small sentence here: we thank Dr. Herman Gross, medical director, San Quentin Prison, San Quentin, California. And I don't think that Dr. Herman Gross was the volunteer. He of course provided the prisoners. And you have seen from our exclusion criteria that we of course excluded prisoners. And this was 1963, and I think the Helsinki Declaration came 1965 or 6 or 7 or so. So just a few years later. This was the time before Helsinki Declaration. And what they did, they went to the prison and they injured the prisoner. Probably they gave them some goodies or some, which would be regarded as totally unethical today, which was standard of science at this time. And these are not bad people, so with bad things in mind, so, but it was the standard of clinical research at that time. Yeah, and of course it worked. It's a histopathology. This is the wound that was left dry on the open air, and this was the occlusively dressed wound. And even if you're not a medical doctor, you can see this looks better than this. No? And that's the situation now. It's the same, not the same, but a very similar situation compared to 1942 when Holmes wrote there are literally, we still have literally thousands of those materials. Of course, the composition changed a little bit based on these on the invention from Winter with moist wound care. We have of course a lot of substances that can provide moisture on the wound, and we still have we on top of that have a lot of other stuff from topical negative pressure to maggots, to mention particularly because they are very prestigious, I would say, and a lot of other things. I cannot go into all of the details with these. To start with wound cleansing, because it's the first step. If you come in contact with the patient with the wound, you cleanse it. No? The question is, why do you do that? And there is, again, I think, no evidence necessary to do that, no? Because cleanness is probably incorporated in the human mind. We find dirt always somehow disturbing and want to remove it, and the same is true for the wound, and probably it's not really useful to ask for why. But of course, to remove any kind of dirt and debris, we also hate odor. Odor is something we do not like generally. The patient doesn't like it, the doctor doesn't like it, and cleansing, of course, helps to remove that. It provides comfort, and we should not forget this. Wound care is one of the major parts of treating a patient, providing patient comfort. It's a kind of Zuwendung to the patient. A very important part of Zuwendung to the patient. We should clean the wound to prepare it for the dressing, because the dressing has to stick to the skin, of course, and the skin has to be clean, otherwise it wouldn't stick. And it might also provide protection from infection, and I will come to microorganisms in a second. So it's evident that we couldn't do without wound cleaning, so we have to do it. We cannot not do it. But the question that is open is, how should we do it? And this is again, as I said, with dressings or with guidelines in before the break. This again is then very confusing. You can do whatever you like. You will find a guideline or a recommendation from any expert who recommends it. You can use water, and the plain water, but the argument is, should it be tap water? Does it have to be sterilized? So nobody knows exactly. Do we need salt solutions? Is it necessary to have a physiological solution? Of course, if you give an infusion, it has to be physiologically from its crystalloid content. But is this necessary if you put it from the outside on your body? I'm not sure whether this is true. But intuitively, we use this because we think it's beneficial. And the debate goes on with using antiseptics. Intuitively, you would think the less bacteria, the better. No? So use antiseptics, and probably this will help the wound to heal faster. But again, this is not shown by any evidence, and there is even a strong argument against, because these, of course, are pharmaceutical agents that might influence also wound healing negatively, and we cannot exclude this. So there is a big debate about antiseptics or not. And then how to apply the stuff, by bathing, by soaking, by rinsing, by applying poultices. Is it possible simply to put your leg into the shower and shower it? So there's a big debate about this, and some people argue in the one direction, some people argue in the other direction. And there is no real definite answer. And for a study like this, we simply have to make a convention that is applicable and that is usable by everyone. And this is what we tried to do. So what about antiseptics? Because there is, of course, there has been recently a debate whether in the diabetic ulcer, which is of course always at high risk for infection, is it useful to use these antiseptics routinely? The literature is controversial, I said this, and the reason is that there's missing clearly evidence. So no producer of those antiseptics that are available has ever done a prospective study like we are planning or starting here. So there is no evidence. The evidence that is available comes from tissue culture and comes from animal models. So this is a rat abdomen. So they put this stuff into the rat abdomen and look whether it's toxic or not. But of course, this does not say anything about whether this is beneficial or not in our patient who looks like this. So practically speaking, we have no evidence from the decade-long use of those substances on various wounds that there is any big deal, any big difference that comes up simply practically from retrospective evidence. So no safety signal, you would say, in pharmacological terms. There is even no evidence that sterility is necessary. For forensic reasons, in the hospital, of course, we use sterile substances because otherwise we would run into a problem with argumentation if the patient acquires an infection. But probably there is other evidence that says that the plain shower at your bathroom is equally effective than a sterile bottle of water. But in a study like this, of course, you would prefer to have sterile solutions to have a standard. I already talked about this. I already talked about the various antiseptics that we have. In fact, this is PVP iodine, it's octenidyne, and it's polyhexanide, and some other minor products that are around. And there's a big argument among the producers and among the users of this stuff, which is better and which is worse. The advantages and disadvantages is more or less, in my view, is more or less the same, and there is no reason to prefer one thing over the other, or the question if you use it anyhow. So you need local standards because there are no general standards. And this applies also, as said, this to a study protocol like we are doing here. You have to develop a standard that is applicable to all patients, and that is possible to do in all participating institutions where you have no major objections. There is a consensus on this point. Don't use antibiotics. Don't use antibiotics topically. Use antibiotics only systemically in case of infection, and we also discussed about the diagnosis of infections. And if you have infection, you have to use the antibiotics systemically, either parenteral or orally. And a very interesting issue, which is under-researched, is the question of microorganisms. You know that the term microbiome is now in everybody's mind and in everybody's mouth and everybody's publications. All aspects of our life are steered by the microbiome on the skin, in the guts, wherever the microbiome sits, and there is no piece of your body without the microbiome probably. And there is a particular microbiome of the wound, of course, and this is not very well investigated. And as I said, intuitively we probably think this is dangerous and we should get rid of it. But I'm not sure whether this is true. There is at least some minor evidence that says the microbiome is necessary to have it there because it's a kind of stimulation of your immune system, kind of stimulation of wound healing per se. So getting rid of all these microorganisms and making the wound sterile probably is not really an advantage. So in fact, we do not know. We know that infection is negative, but colonization with kind of a certain mixture of microorganisms might not be so bad. No? It's good to know who they are. So what you should do, particularly in a wound like diabetic foot ulcer, which is, as I said, always at a high risk for infection, is to know which bacteria are there. In case of infection, then you have your antibiotics ready to use. And so particularly in these patients, at least we at our institution do regular swabs to investigate the spectrum, so to know at what risk our patients are. So now we have cleaned the wound with water or with sterile salt solution or whatever. The next point in wound care is debridement. The wounds are often covered with necrotic stuff, crusts, fibrinous layers, this yellow stuff that you can see here. And intuitively we assume if we take this off, if we remove this, the wound will heal better. There still is no evidence for that. But again, practically speaking, you cannot avoid doing that. And from practical experience, it's so obvious that you cannot get rid of doing that. There are various ways of doing that. The most efficacious, of course, is taking a knife or another sharp instrument, scissors or so, and simply cut it off. This, of course, works instantly. The disadvantage is, of course, it's painful and bleeding, and sometimes a little bit problematic for the patient. So there are other ways. Autolytic is the modern term. You use hydrogels like Nugel, for instance. With Nugel, you can you provide much humidity to dry crusts and necrotic tissues, and this can then be softened and removed by the body. That's the reason why it's called autolytic. If you have a tendency to what I call exotic or bizarre medicine, you of course can use also maggots, because they also do it very efficiently. But the question is whether it's really necessary, or whether you do it just to impress your patient or impress your colleagues or impress yourself by showing what a glamorous doctor you are, because you are head of the maggots. Lord of the Flies, yeah, you are the Lord of the Flies. So we don't use that, as you probably already guessed. And now we have now debrided the wound, as we did and as we will do in the study. Remove all the debris and the hyperkeratosis around. Now we have to dress the wound. Of course, this is also unavoidable. We have to dress the wound. We cannot leave it open in most cases. And this is what Winter invented. Winter invented to cover the wound with a kind of semi-permeable dressing. Semi-permeable meaning the fluid stays in, but there is a gas exchange. And it needed from 1962 or 3 to 1990 or so, when the first products came to the market. And the reason why this took so long is that Winter's invention, simply putting a film over the wound, is not practicable in a chronic wound, because the chronic wound always produces fluid. And if you put the plain film over the wound, which is adhesive, the consequence would be that you would kind of have a kind of a lake below the film that will earlier or later be spoiled and stain your clothing and smell and be not practicable. And what has been invented was what they called interactive dressings, and this simply means dressings that absorb the fluid, that have a kind of absorption potential for water fluids and swell with it. And with this swelling, the moisture is kept in the wound and the dressing follows the form of the wound. So this was really a big step and advantage, and it has become standard of care for many, many wounds. And we discussed before the break that there are some reasons not to do it, but in most cases, in most wounds, we prefer this kind of treatment. It was very comfortable for the patient in most cases. So wound dressings are an important part of patient care, and again, this is a very important Zuwendung. So the patient is very important to the patient that you choose a dressing that is comfortable, that allows for painless changing and so on. So you have to have a little bit experience, because not all of these materials are suitable for all wounds. You have to take care for patient comfort, I said this, for availability. for experience, you have to know how to handle these materials, and of course for cost, because some of these materials are exceedingly expensive, and all hospitals I'm aware of have kind of wound commissions where they select those products according to cost and according to clinical need. I said this, most dressings should be preferred except for deep, perforating, and for infected wounds. We discussed this, and this is the situation that we probably in some patients have. And we have to keep in mind that inappropriate dressings can be bad, but within the selection of dressings that are good, the variability is very high. And the mistakes some people do is to take it too important. It's not so important which kind of the appropriate dressings you use. The most important thing is to find the causal factor. So what's wrong with the extremity? What's wrong with the area that is wounded, that the wound cannot heal? Is it ischemia? Is it mechanical pressure, like in our diabetic foot patients? And it's no use to use Aposec for months and months and months if the patient keeps walking on his foot. So you have to always eliminate the causal factor if you can, because otherwise the wound would never heal. Pharmacologically active substances in wound dressings incorporated should be generally avoided. We had a phase where they tried to put anti-inflammatory substances in dressings. This has turned out not to be useful, in most cases even detrimental, causing contact sensitization and other problems. And evidence levels are generally low, and this I think with this, I think I come to the end to think with you together about what about evidence in wound care. And if you ask most people, do we need more evidence for those types of dressing? Most people will answer intuitively yes, because having a randomized prospective controlled trial in medicine is always good. You always want to have it. So the quick answer is yes. But if you think about it, the real answer probably is only sometimes. Because if you have a simple plain wound dressing, like a foam dressing, why would you ask for a randomized control trial comparing the foam dressing versus a standard gauze dressing? You know, the consequence would simply be you wouldn't have the foam dressing, or it would be so exceedingly expensive that you wouldn't buy it. Or in other words, you don't need a randomized control trial for Hansaplast. You simply go to the pharmacy or to the drugstore and buy it. Because if you had this study, there wouldn't be a Hansaplast. So you don't need it for this. You probably should have it for this, because there are so many products like honey around where the producers claim the most fantastic effects of the stuff, but have no evidence and sell it anyway for a high price. And this rises a lot of healthcare costs, which are probably avoidable if they had some evidence. And I'm sure much of this stuff could be eliminated, which is still around. But you need it, of course, for the things we are investigating here, because otherwise would be impossible to use them without, because this is in the area now of pharmaceutical drugs, and they should, of course, be thoroughly tested like any other pharmaceutical drugs. So, having discussed this, the final question is, what do we need in clinical practice? And this comes close to the question, what should we do in a study like this? What you need, or what we need in an institution where we treat patients with chronic wounds, we need only a few materials. And with these few materials, we can do almost everything. And the few materials is non-sticky gauzes, mainly Vaseline impregnated grids that can be put on the wound that are not sticky, so can be removed without pain. We need super absorbers. They're very, very similar to these modern napkins for the babies. They can absorb lots of fluids without giving the fluid back, which is, of course, very comfortable to the patient. We need the old film dressing still, the very same or very similar stuff Winter used on his pigs, because they are very, very convenient to fix, so to stabilize other dressings on the wound. They are the so-called hydrocolloids, which have a very similar effect, function than the film dressings. Foams are very, very convenient, and the most commonly used dressings around, I guess. Hydrogels an example for hydrogel is Nugild, so the stuff that is used here, which is kind of a wound filler. If the wound is dry, you use a hydrogel because it provides much watery fluid, which is beneficial for a dry wound. You shouldn't do it on a wound that is that has a lot of secretion. And you need some filling stuff for penetrating wounds that are moist, that can take up the fluid. And there are also there are some of those materials, of course, around. And if you have this in your ward, if we have these substances in our offices and in our patient wards, in outpatient wards, we can, of course, take care for all imaginable wounds. And that's my final slide, and I thank you for your attention. I'm, of course, open for any questions you might have.